This is SCAI 2019. I am Shad Reyes coming from Las Vegas. With me is Rahul Sharma, Anita Asgar, and Paul Sorajja to talk about new frontiers in structural heart disease. So starting with you, Rahul, what is the new up and coming beyond what we learned from ACC, low-risk TAVR? Anything new, new devices, PVL, and or management of coronary and structural heart simultaneously?
Yeah, that's a loaded question, but I think just when we think we've out-TAVR'd ourselves, there's always something new in the TAVR space. We have exciting devices coming down the pipeline that are currently being studied in clinical trials, one of which is a self-expanding system that has an anchoring system, another that's being studied in patients with severe aortic regurgitation who are high risk or prohibitive risk for surgery. So it'll be interesting to see the results from those trials and where those devices settle out. We also have a third valve hitting the market, and that's going to be exciting to see how that impacts our patient care. We have a new understanding of novel techniques at protecting the coronaries during high-risk TAVR cases and high-risk valve-in-valve TAVR cases, using basically electrosurgery to modify the valve leaflets and prevent coronary obstruction, thanks to the work of some very innovative people in our field. So new devices, new techniques to further optimize high-risk TAVR patients. And lastly, I'll say that there's also exciting results, both based on registry studies and anecdotal studies, at using intravascular lithotripsy to make non-transfemoral patients into transfemoral TAVR patients. So from access to device to coronary protection, TAVR continues to forge on with new developments and new technologies.
So with all nice introduction from Rahul, Anita, how do you keep up with all these devices in your practice? I mean, there's people who is practicing structural every day, but there's every day there's something new. So how do you keep up?
I think you really have to have a focus and decide, what is the area you want to excel at and put your focus there. So for me, I've really tried to focus on valvular aspect of structural, so I don't do LAA occlusion, but I try to focus my energies on mitral, aortic, and now the exciting work that's coming along with tricuspid. So, and I think those patients all go well together, and you build a network of referrals and heart failure specialists that you work with that make that rewarding.
So speaking of tricuspid, Paul, are we ready for tricuspid?
Oh, it's a very exciting time. So we have the Triluminate pivotal trial, which is launching in the U.S. in the next month or two. And it's very exciting to see as the first device or the first trial that's going to be tested in a controlled fashion for treatment of patients with TR. I think we have a lot of expectations built into this trial about understanding whether or not we can impact the prognosis of these patients. And it's been a lot of fun to see it come together because we're all learning. It's, I think for a lot of us, TR has been previously described as a forgotten valve, but it's relatively unstudied. In other words, it's really a black box in terms of the definitions, the endpoints, the goals, and what have you. It's going to be really great to see how that evolves over the next several years.
Now, shifting to the mitral space, there is some discrepancy, as you know, from the European experience and the American experience in the results. So how do you really fine-tune your patient before really ultimately send him for a mitral clip? Especially, I'm talking about the functional MR.
Yeah, I think you have to understand that the two trials are different but complementary. And they help us really identify who are the patients that benefit and who doesn't benefit. And I think, both are very good for helping us to refine that patient population and fantastic for the field of functional MR, because now we know that if you can treat functional MR, you can change prognosis. It's just carefully selecting the right patients.
So Rahul, how do you, if you get a 60-year-old with severe AS, would you offer him TAVR and surgery, or how do you reconcile that?
Yeah, it really is a heart team decision. I think it's going to be a factor of patient preference, patient anatomy, and of course the likelihood of TAVR-related complications as well as surgical AVR-related complications that may be unique to some of those younger patients. And then alongside with that, the younger patients with bicuspid anatomy and how you approach those cases. I think there still needs to be more data to understand what the right thing is to do for those patients. But I think in 2019 and beyond, everyone who presents with severe aortic stenosis, who needs an aortic valve replacement and is symptomatic, it's going to really be a multidisciplinary heart team decision to understand what the right thing is for them, particularly with low-risk patients.
Paul, you're in a lot of writing groups for your guidelines. Do you see this is going to change the last two trials with low risk? It's going to change the guidelines soon?
I think so. I mean, the data are very supportive. And when you look at the valve guidelines, there actually are not a lot of randomized trial data out there. Most of the level evidence is B or C, and so when you have level evidence at A coming to being available, it does impact the way people think about the guidelines. So I do anticipate that they will change. There will always be some caveats and concerns about durability and things that we'll have to consider, but at least the early data are very suggestive and show the benefit of TAVR in those patients.
There is some concerns was from one of the interventional council of the National Society about we are less offering TAVR for African American. What do you think that gap is and how we can fill it?
I think that's a challenging issue to really kind of piece apart. I mean, obviously, I think one of the main reasons would be access to care and referral of those patients when they have severe aortic stenosis, and that's something that a lot of work has to be done to improve that. Beyond access to care and finding the appropriate patients to refer, the reasons for that may be very complex. I'm not sure I really fully understand that, but I think that's something that we've all probably observed in our practice. A lot of challenges in trying to improve and bring this technology to all people who need it and who are appropriate.
If I may chime in,
please.
So we actually have an investigator-initiated research study that's sponsored that's trying to address disparities among African Americans in Minneapolis, and it's very interesting that we've learned a number of different things. I mean, first of all, if you look at the history of medical therapy in African Americans, you go all the way back to the Tuskegee incident with syphilis and the way they were treated. There's this real hesitancy about research and then innovative stuff that is invasive, and there are so many barriers that go way beyond just the local access that I thought this was about. I thought it was just local access, but it's so much more than that, and we have a lot of work to do there.
And you were talking about Minneapolis. How about you extrapolate to the whole U.S.?
Oh, it's even more.
Even
more.
Do you have the same issue in Canada?
We do, but we're mostly limited by geographic distances. So we have a small population, dispersed across a large area, and so getting access to care is difficult from geographic limitations. So we're struggling on that front.
Well, it was a great time talking to you all. I mean, really learned something new and really exciting time for structural heart. Please watch this video and others on SCAI-TV and also on clickattrial.com. Thank you.